Thank you for the opportunity to present this work on sex differences in mortality. So in the general population, females have a survival advantage over males. This can be attributed to biological reasons such as immune response, but also the way in which they engage with the healthcare system. Chronic kidney disease does manifest differently between sexes. CKD is more prevalent in females, but males have a faster progression to end-stage kidney disease and so represent a larger proportion of the ESKD population. This could give rise to systematic differences in care. Women are already known to have poorer kidney function at dialysis initiation and have less access to kidney transplantation. So our study sought to evaluate the impact of ESKD between sex in terms of mortality, and this is both within the ESKD population but also relative to expected survival outcomes in the general population. And while we expect people with end-stage kidney disease to have greater mortality, we do not expect relative measures of survival to depict sex differences. So we use data collected in the Australian and New Zealand Dialysis and Transplant Registry, which collects information on everyone who initiates kidney replacement therapy in Australia and New Zealand. And in this way, we were able to identify the incident ESKD population in both Australia and in New Zealand. We then linked to national death registries, which was a national death index in Australia, where available data was between 1980 to 2013, and the mortality collection database, where available data was between 1988 and 2012. In this way, we were able to ascertain all the deaths and their causes to ICD coding, which is an internationally agreed classification for causes of death that allows for between population comparisons, and it's also used globally. To look at the sex differences within the ESKD population, we compared their causes of death and mortality rates by age. And to look at this relative to expected survival outcomes in the general population, we estimated standardized mortality ratios, relative survival and the excess mortality ratio that goes along with it, and life expectancy to estimate life years lost. And for some of these measures, we did look at the subpopulation of kidney transplant recipients. So overall, a little over 60,000 patients were included. Males represented the majority at 60%. They had similar median follow-up times, and the proportion who died was similar between our sexes. The vast majority were from Australia, and females did have a higher proportion with Indigenous ethnicity and a higher proportion who were underweight. While in the males, a greater proportion had ever smoked, had coronary heart disease, peripheral vascular disease, and who were overweight. In our subpopulation of kidney transplant recipients, roughly similar proportions of our females and males received a kidney transplant and thereafter died. So looking at our causes of death, this is by sex here and age at death, and our cause of death is categorized broadly based on the ICD codes. Visually, we can see that the patterns are strikingly similar between our sexes. Of note, there were some minor differences. So for cancer and for cardiovascular disease in those aged over 35 years, males had a 3 to 5% higher proportion dying of those causes. While for chronic kidney disease in those aged over 50 years, females had a 5 to 6% higher proportion dying of those causes and possibly attributed to treatment withdrawal. Looking at our mortality rates by age, we do see that these are similar between our sexes with no significant differences, and this increases with older age. Once we start comparing to the general population, we do start to see differences. So in the second plot is standardized mortality ratios, and this compares the number of deaths we see in our ESKD population to the number of expected deaths we see in the general population based on someone of that same age, sex, calendar year, and country. The impact of ESKD is more profound in our women where they have a greater amount of excess deaths. In particular, younger females have the greatest excess deaths, where in those aged 18 to 34 years, females experience 50 times the number of deaths compared to what is expected, while males are only experiencing about 15 times. Still looking at these excess deaths now by calendar year, we see that females with ESKD continue to experience a greater number of excess deaths for our entire study period. This is decreasing in both our females and our males, and the significant interaction terms suggest it's decreasing at a faster rate in our females. Regardless, even in 2012, females are still experiencing 8 times the number of deaths, while our males are experiencing about 6 times the number of deaths. Continuing to look at excess deaths now by cause of death. Overall, females have around 12 times the excess deaths and males have about 7 times the excess deaths. However, we do see that this sex disparity differs by cause. So for cancer, this is much the same between our sexes, but it becomes much more prominent and higher excess deaths in our females for causes relating to cardiovascular disease and gastrointestinal disease, which includes liver disease, peritonitis, and diverticular disease. Looking at our relative survival estimates, and this considers all the deaths that are occurring in our ESKD population, and it compares the survival that we get in our ESKD population to the expected survival we get from a general population over follow-up. Again, this is adjusting for age, sex, calendar year, and country. And so what we do see is after 10 years from ESKD diagnosis, around 39% of our females with ESKD are still alive compared to what is expected, while our males, this is higher at 43%. And we can get a measure of what this sex disparity is over time, and this is captured in the excess mortality ratio. And this suggests at any given time, females are experiencing a 9% higher excess mortality than our males. And in our subpopulation of kidney transplant recipients, we see that the relative survival has drastically increased, so a greater proportion are alive compared to expected, and this sex disparity has diminished as well, and in fact is not found to be significant in the excess mortality ratio. Now looking at our life expectancies, and here we're presenting the expected life years remaining at ESKD on the left and age at first kidney transplant on the right. So we see that the expected life years remaining are very similar between our females and our males across age. And if we bring in our expected life years remaining from our general population, we can start to see that this female survival advantage that we see in our general population is not reflected in the ESKD population. And seeing both of these estimates together lets us gauge what our life years lost is, and this is the difference between what we see in our general population to what we see in our study population. And so just looking at these life years lost now, we can see that there are much more life years lost in our younger females from ESKD, and this is reduced but still apparent in our kidney transplant recipients. So at age 25, our females with ESKD are losing around 32 years of life, while our males are only losing about 26 years of life. And across all these ages, females from ESKD have about 5 to 6 more life years lost compared to the males, while from kidney transplant, this reduces to about 3 to 4 more life years lost. So in conclusion, our sex differences within the ESKD population were minor, but these differences became much more apparent once we compared to the general population. The impact of ESKD on mortality is more profound in women than men, where females have greater excess deaths, poorer relative survival, and more life years lost. The greater sex disparity was seen in the younger ages and from certain causes of death. There were improvements over time, and kidney transplantation did lessen these sex differences. However, if the impact of ESKD is worse on our women, how can we address this, and how is this arising? Is this due to physiological reasons, access to healthcare, sex-specific, the need for sex-specific interventions, or a bias in health service delivery? And again, this is along the lines of providing the same care for everyone may not result in the best outcomes, but providing them with the care that they need will. And finally, I'd just like to acknowledge all the organisations that made this work and also our investigators that made this work possible. Thank you.